Welcome to Pulmonary Pathophysiology. Some of the minor types of respiratory ailments, such as dyspnea, which is a shortness of breath, or cyanosis, where you don't have enough oxygenation of blood, uh, are kind of minor um, pathophysiologies. And they wouldn't be more than two-point questions on the exam. Um, However, what is next slide is going to be very important. And that has to do with respiratory failure. There are two patterns, and one is hypoxic respiratory failure. I don't need you to memorize the numbers, but what happens is if the amount of oxygen in arterial blood goes down, you've got ischemia. And that means that the cells of the body are not getting enough oxygen. The most common example in patho books is ARDS. And we're going to talk about ARDS next, but it stands for Acute Respiratory Distress Syndrome. It can come on very quickly. It can be fatal within 48 hours if not treated. And it is basically pulmonary edema. Now, the pulmonary edema is brought on by, I'm going to use an example, and that's going to be aspirating vomit. And I know that's kind of a weird example, but um, often if somebody drinks too much alcohol, alcohol is, you're going to find this in pharmacology. Alcohol, unlike many toxins, is not excreted at a larger rate if you drink more. And that's usually what happens with drugs, is that if you take two instead of one, then the body will excrete more. Alcohol, no. Alcohol, if you drink too much, it just excretes a small amount, and that can lead to alcohol poisoning, which depresses a lot of depresses a lot of reflexes, and one of which is the epiglottis closing properly, which would mean that fluid would not enter the respiratory tract. So you could have a situation where a person has imbibed in too much alcohol, it's depressed their central nervous system, and they throw up, they vomit. And what can happen under those conditions is that they can aspirate the vomit into the lung because the epiglottis is not functioning properly. And that brings on an immense reaction where you're going to have lots of inflammation, and you're also going to have a situation where the oxygen is not able to penetrate through the layer of vomit that is in your alveolar sac, and it leads to pulmonary edema, and it can be fatal in a very short period of time. So the thing about ARDS, however, is that it's the oxygen that can't get in, but the carbon dioxide can bubble through the vomit just fine. So it's just an oxygen problem, although that can be fatal if the brain doesn't get enough oxygen. It can then shut down, go into a coma, and die. So having said that, the next pattern is the more common of the two patterns, and that is hypoxic hypercapnic respiratory failure. Now, the low O2 is hypoxic, and however, a very high carbon dioxide level in arterial blood is called hypercapnia. And again, don't memorize the numbers, but there are going to be situations, especially with the COPDs, the chronic obstructive pulmonary diseases, like chronic bronchitis and emphysema. Usually asthmatic attacks are not that lengthy, please God, not that lengthy. And so it's something that the respiratory failure being type 2, it is during the asthmatic attack, but there's quick recovery after. But if it's a chronic type of disease and a progressive type of disease, and it could be chronic bronchitis, or it could be emphysema, or it could be TB, or it could be cystic fibrosis, or it could be viral pneumonia, where people have it for a long period of time. It could be months, it could be years, kind of depending. And the thing about that is that you're going to have two things happen that will cause respiratory failure. And that is that you can't oxygenate the body enough and you can't get rid of the CO2 quickly enough. And if you can't get rid of the CO2 and it spills over into arterial blood, you've got acidosis. And then if hypercapnia continues and is not mediated, then that acidosis can lead to central nervous system effects, such as convulsions. I'll just choose that as an example. And then if it's not remedied, coma and death. All right, so pulmonary disorders, ARDS, which is a type 1 respiratory failure pattern, asthma, chronic bronchitis, emphysema, pneumonia, TB, and cystic fibrosis are all type 2. In all of these cases, for different reasons. You don't oxygenate the body properly and you don't get rid of enough CO2, and so complications like acidosis can ensue. So all of those are type 2 hypoxic hypercapnia respiratory failure. Okay, so here we do. So ARDS, your acute respiratory distress syndrome, is a form of pulmonary edema that comes about very quickly, and it has to be treated quickly. And you don't need to know all the nicknames for ARDS, but this does give you an idea. Within 48 hours, death can occur if it is not diagnosed and treated. So I'm going to kind of summarize this. What happens with the example that I will use on the exam is aspirated vomit or aspiration of gastric contents. And then once that happens, needless to say, here you have vomit with a very acidic pH. And now it's going to be very difficult for the alveolar sac to exchange O2 and CO2. But it's not going to be a problem with the CO2. It's going to be a problem with the oxygen. Because the CO2 can bubble through the noxious vomit, and the person can exhale CO2, but the oxygen does not, it's not soluble in water, and it's certainly not soluble in vomit. And so it doesn't actually, it's not able to exchange the CO2 and O2, so you end up with arterial blood that's extremely low in oxygen. The vomit is going to trigger inflammatory cytokines or signals such as histamine, and that is going to exacerbate the pulmonary edema. Now, meanwhile, back at the ranch, decreased blood flow, alveolar damage. It can actually cause alveolar collapse. You're not going to get the oxygen in because it does not dissolve in vomit. And then the CO2 is able to be exhaled, but that brings you into that type 1 hypoxic respiratory failure. Obviously inflammation, here are your phagocytes, and that's going to cause pulmonary hypertension, but the pulmonary hypertension is kind of the least of your problems. What's really killing you right now is the vomit in your alveolar sacs. So this is a great example of it, and what I'm going to draw your attention to is right here. Do you see the oxygen, the O2? And so the O2 hits this wall of water or vomit or whatever it may be, and then it just cannot dissolve in that. So it's just going to come around and come back out. In fact, you'll actually be exhaling oxygen with your CO2. And without oxygen, the brain's just going to shut down, and coma and death will quickly ensue. I don't need you to know about mods. That just means that things can go from bad to worse. And death being the worst outcome of all of this. But I'm not going to test you on MODS on the exam. All right, now we have our chronic obstructive pulmonary diseases. And that is going to be asthma and chronic bronchitis and emphysema. So asthma tends to be a trigger of something that the person is allergic to. And then when they have an acute reaction to that trigger, then you're going to start to go down that road of inflammation. So I am going to go to the next slide. And, oh, okay, so this is showing you a person who is not experiencing an asthma attack. And this is a person who is experiencing an asthma attack. And you can see why it's a type 2 respiratory failure. It is both hypoxic and hypercapnic. Look at how large those bronchi and bronchioles are normally, and look how incredibly reduced they are when a person is having an asthmatic attack. So you got bronchoconstriction, you got the goblet cells producing too much mucus, and it becomes extremely difficult to either take in a breath or to exhale a breath. So if you can't inhale, you cannot deliver oxygen. If you can't exhale, you trap the CO2 in the body. And that means that the arterial blood is depleted in oxygen and has way too much CO2. So as well as the problem with the O2, you have the problem with acidosis with the high CO2. So that's why it's type 2 respiratory failure. So here we go with the pathophysiology. It's going to be the trigger that produces or that binds to the IgE, which is bound to mast cells, which releases not only histamine, but leukotrienes. And leukotriene is another type of very active inflammatory signal molecule, a cytokine. And it is so prevalent and prominent in asthma that when you take pharmacology, you find that asthmatics not only take antihistamines, but they also take anti-leukotrienes. Prostaglandins is another inflammatory molecule, and in this particular case, it acts as a stimulant or an enhancement of histamine's mode of action. So histamine is going to bronchoconstrict the large bronchi, and leukotrienes are going to bronchoconstrict the smaller bronchi, which means that it is going to totally bronchoconstrict the entire system in the lungs, in both lungs. And that obviously is going to make it very difficult to inhale and exhale. Now, histamine can also stimulate the goblet cells. They're scattered through your lungs, and what they do is they make mucus. Everybody makes it, but it's in healthy people, it's very watery. In people during an acute asthmatic attack, it becomes very thick and hard to dislodge, and a lot of it. And so that is going to make mucus fills the lung bases, inhibiting alveolar ventilation, which means breathing, inhalation, exhalation, and there's no good compensation except for an EpiPen, which would instantly reverse the symptoms. And this is, again, just another example where you've got the bronchoconstriction and the excess mucus. Now, chronic bronchitis has a lot of similarities to an asthmatic attack, except for the fact that it is triggered by long-term smoking. And so I'm not going to test you on how many times a year a person has to get bronchitis from smoking that then turns from an occasional bronchitis to a chronic bronchitis. But that does happen as the person continues to smoke. So you have the irritants from the smoke causing the inflammation. The reason for the hypoxic and hypercapnic type 2 respiratory failure is, again, that it's going to start to do the same thing. You're going to have the histamine release. You're going to then have the goblet cells increase their mucus. There is no leukotrienes in this particular disorder, however. Um, and when the ventilation is low, and this can happen in emphysema as well, perfusion will become low, and that can cause pulmonary hypertension because you want to have perfusion, ventilation equal, ventilation, perfusion equal. And if the ventilation goes down because of chronic bronchitis, then you want to have the perfusion go down. And the way they do it is by vasoconstricting the pulmonary arterioles. And since emphysema is chronic continuous and chronic bronchitis is over a long period of time with repeated cycles, you can set up that pulmonary hypertension. That means that the right ventricle is going to have to become hypertrophic in order to push that, or in order to bulk up and contract more forcefully to push that blood into the pulmonary arteries. That will eventually weaken the right side of the heart and it can collapse. When that right side bulks up and becomes enlarged, that's called cor pulmonale, and that's a something you can pick up on imaging, and that becomes very severe quickly and can cause the collapse of the right side of the heart with death quickly ensuing. So this just goes into some of the pathophysiology of chronic bronchitis. You have the hypertrophy of the airway, hyperplasia of the mucus glands, so you got a lot of mucus. Ciliary damage, because the long-term smoker is going to have metaplasia and replace the columnar epithelial with squamous cells, which don't work. And that is all going to mean that you're going to have that bronchoconstriction, that increased mucus. And this part is something that is not going to be with asthmatics. And an asthma attack tends to be pretty finite, where chronic bronchitis can unfold over a period of weeks. And that is that mucus, if you can't get rid of it quickly, becomes a breeding ground for pathogens. And very often there is a respiratory tract infection that occurs because of pathogenic bacteria, especially being able to colonize and feed off the mucus. So very often people with chronic bronchitis are taking antibiotics as well. Okay, so this is another lovely diagram. Here's your alveolar sacs. Here's a terminal bronchiole, and you can see all the mucus, and it appears to be constricted, and so it's going to be very difficult to ventilate, very difficult to inhale and exhale. And again, the mucus is around for a long period of time, like a week, 10 days, and that becomes that breeding ground. So very often they have to take antibiotics as well because of that. And then emphysema. Emphysema is perhaps one of the reasons that long-term smoking kills. And it is because the macrophages that are in your alveolar sac to protect you become remodeled with the long-term smoking. So they produce very pathologically a whole bunch of proteolytic enzymes called proteases. And elastin or elastic fibers are proteins. And it makes your lungs have the ability to inhale and exhale, to expand and contract. And these proteases are going to start to destroy the elastic fibers and destroy the elasticity of the lung. And that's going to be very difficult, especially for exhalation, which relies on that elastic snapback in order to force that CO2 out of the body. There's a term that is used that I would like you to know for a 2-point question, and that's a sinus. or asinus, depending on how you pronounce it. But this has to do when you're describing a person who has emphysema. What they're really trying to explain is these terminal bronchioles that then end up creating the alveolar sacs or end with the alveolar sacs. And what is going to happen is that the alveolar sacs are definitely going to be primarily destroyed, but you're also going to have complications in these terminal respiratory bronchioles. More about that later. But when you have the terminal respiratory bronchioles and the alveolar sacs, these are called, they're like a complex called the acinus. All right, so why is that important? Well, this is normal, this is abnormal. And I'll come back to it in a second, but I want to go into the pathophysiology and then show you the picture. So everybody has macrophages in their alveolus to protect them against any pathogen getting there. The problem with the macrophages is over a long period of time, the smoking makes them function differently. So they produce and release these proteolytic enzymes, which they should never do, and they start to destroy the elastin protein fibers, and that's going to cause the lung to not be able to expand and contract, and the elastic recoil of exhalation becomes compromised as well as the inhalation. Now, this enlargement of the air spaces, I'm going to show you in a second, but let's show you what's going to happen as far as, see the alveoli, they should have shown a macrophage in here. They didn't, bad people. But the reason why these are so holy and destroyed alveolar sacs is that that's where they start. The proteolytic enzymes are released here. So this is where you're going to have the most damage. And you're also going to have some constriction of the terminal bronchi or bronchioles. So needless to say, that alveolus that you're looking at right now is totally useless. It's gone. It can't be replaced. And that person has lost permanently a certain amount of respiratory capacity. And to make matters worse, so this is the breakdown of the alveolar. Damage that destroys alveolar walls can't support the airways to keep them open. And very often what will happen, especially in exhalation, you can't do it or you can't do it properly, and you trap carbon dioxide in the lungs. And it will then trap the CO2 because you can't get it exhaled totally, so it gets trapped in the bronchioles, and it produces a hyperinflation or a balloon-like effect of the alveoli, and we call it a bulla, B-U-L-L-A-E. Very often, people who have emphysema seem to have a barrel-like chest. It really sticks out, and a lot of that is due to all of these hyperinflated bulla, and I'll show you that over here. So here is alveolar sacs, and here is a hyperinflated alveolar sac, and that is all trapped carbon dioxide, and that's what they mean by a bulla. And the loss of the or the destruction of the alveolar sacs can be imaged, and so this is loss of lung tissue, permanent, and that's the reason why emphysema is a chronic progressive disease where there is no cure. Also remember that you have the same type of thing that you do with chronic bronchitis. You have a decrease in your ventilation that is going to cause a decrease in perfusion because ventilation wants to equal perfusion, and that then is obtained by uh, vasoconstriction, causing pulmonary hypertension, which can then put a big strain on the right ventricle, which can start to do hypertrophy and enlarge, and that's called pulmonary. And if that is not remedied, then the right side, which is weaker than the left side, will just totally collapse and the person dies. So that is a lot of the pathophysiology of emphysema. And that brings us to pneumonia. The pneumonia that we're going to talk about is going to be just bacterial and viral. Um, the pneumonias that AIDS patients get, which tend to be fungal, I'm not going to cover. I'm just going to cover the common bacterial viral pneumonia. And pneumonia, it says, is an acute infection of the lung parenchyma. Now, the parenchyma is again a combination of many bronchioles as well as the alveolar sacs. So it's a larger area of the lung that's affected, where the acini are just the terminal bronchi leading to the alveolar sacs. And I'll explain why it's different. And so a term that is often used by pulmonologists is that there's extensive complications or infection of the lung parenchyma. So the thing is that you can classify pneumonia upon imaging either bronchopneumonia, which is going to be kind of random patches in the lung, versus lobar pneumonia, which is just in a lobe of the lung and not in other parts of the lung. And viral, bacterial, and perhaps one of the most famous causes of bacterial pneumonia is pneumococcus pneumonia. Okay, so again, what I want to show you is this image right here. This is an example of lobar pneumonia. You see your three lobes on the right side of the lung, where bronchopneumonia, you can see, is dispersed throughout the lung. So let me go back, because either one of them can be bacterial or viral. Okay, so bacterial pneumonia, the initial infection is in the alveolar sac. And the macrophages in the alveolar sac become involved when the bacterial pathogen enters the alveolar sac. And of course, what it wants to do is to phagocytize it and remove it. But by doing that, it's causing an inflammatory reaction. And that inflammatory reaction can release histamine and cause inflammation and edema. Now, sometimes what can happen in extreme cases of bacterial pneumonia, you can have the partial or total collapse of a lung, atelectasis. And it's unusual, but it can happen. On the other hand, viral pneumonia is not an infection in the alveolar sac. It's an infection of the bronchial epithelial cells. So a virus can destroy the bronchial epithelial cells or infect them, and then that causes an inflammation. And what occurs is that you start to have the histamine be released by the epithelial cells, which causes the edema in those bronchioles. And that can then spill into the alveolar sac, but the edema in viral is the bronchi and the bronchioles versus bacterial, where the edema is going, and the infection is going to be in the alveolar sac. In both cases, you can get inflammation and accumulation of fluid in the alveolar sacs just by either directly by the bacterial or indirectly by the viral. And what can occur with a pneumonia is that you can have drainage of that edema, so medically, it's not a medical emergency as ARDS is. But I want to bring ARDS back into this because you can have aspiration pneumonia. So in some people, the aspiration of the vomit is perhaps not that much, or it's not that extensive, but so it's not causing ARDS, it's causing pneumonia instead. And so it's considered a secondary pneumonia. Due to the aspiration, it starts to um, end up creating the same type um, of edema, and it makes the lungs very sensitive to invasion by bacteria, more so than virus. And so you could have some aspiration of vomit into the lung. And then that means that it's not that extensive, but it becomes a breeding ground for bacteria, leading to a secondary bacterial pneumonia. Now, whipping right along, TB, tuberculosis. And it was a major killer back in my grandfather's time, back in the early 20th century. And then antibiotics, and it became something that was eminently treatable. And then came HIV and AIDS. So a person who has an acquired immune deficiency can very often succumb to TB. So TB is caused by Mycobacterium tuberculosis. And I know that that was covered, you probably did an acid-fast someplace in microbiology and looked at Mycobacterium. Now, Mycobacterium is a slow-growing but very, very persistent bacteria and can end up forming what are called granulomas. These are like little tight cysts that can have inside of them dead lung cells. So when you have a granuloma filled with the dead lung cells as well as the bacteria, you call them caseation. And that can then progress to fibrosis and cavitation and permanent loss of that area of the lung. You permanently destroy the alveolar sacs, and that person is down so much of their respiratory function. This has to do with how in the olden days people acquired TB, now it's AIDS, and so forth and so on. So when this is the thing about the pathophysiology of it, and so I'm going to try to I'm going to try to explain this. You can be in a situation where you come in contact with a person who has an active case of TB. You can be exposed. The bacteria can get into your lung. What will happen, and this is actually explained better in the next slide, is that the lymphocytes, specifically the T lymphocytes, are going to respond extremely quickly. And what they do is they will take the mycobacterium and wall them off. And that's going to be your granuloma. Now, it's a really smart move for that third line of defense to do that and to wall them off, because what they're trying to do is they're trying to make sure that there's no blood vessels in the area so that they starve the mycobacterium and it should die. And the person then goes into remission. The thing is that the bacteria don't ever die. They are able to enter into a state of suspended animation. And those mycobacterium really are almost alive, but they don't die, so they're not dead. And if a person has a healthy immune system, that's going to be fine. They're going to have an inactive case of TB, they're in remission, and they could have a normal lifespan and be very healthy and die of old age. It's when you have the reappearance. So what can happen is you have an AIDS patient and they have an acquired immune deficiency. So their T cells are compromised. When that happens, then somehow that mycobacterium knows that that immune system, third line of defense, the lymphocytes, are dead in the water. And they will reactivate and they will break out of that granuloma and start to actively infect the lung again. So the body's between a rock and a hard place. The immune system is compromised with the lymphocytes, so they have to fall back on phagocytes, specifically macrophages. Now, Mycobacterium tuberculosis does something that no other pathogen does, and that is it's not killed by the not killed by the phagocyte. The phagocyte engulfs it, and the tuberculosis, or the tubercle bacilli, they're called, actually not only avert death, but they use the macrophage as an incubator to grow and divide. But that's the only defense you have. And so the body sends more macrophages as the other macrophages die, but they're also then spreading all that TB. And so the lungs actually can have their alveolar sacs be destroyed more rapidly when the person comes out of that remission. And they are a person that has AIDS. And there's no way that you're going to restore the person's lymphocytes and their T cell function. So as the macrophages come and they come and they come, then the tubercle bacilli, that Mycobacterium tuberculosis, just grows in numbers and grows in numbers and grows in numbers. And that is the way, and it also can spread, but I'm not testing you on that. But because now the lung is filled with Mycobacterium tuberculosis, you will have the granulomas become larger, and you have more caseation, and eventually you'll have cavitation. You'll have this horrendous cavity that you can image. And the problem, obviously, with that is that lung function is gone, and it just continues and continues in the person until the person dies. So these are normal lung, abnormal lung, normal lung, lung with TB. So the cavitation is picked up quite easily, and you get this positive feedback loop, which then can lead to death. So that's the lovely story about TB. And last but not least is cystic fibrosis. It is the most commonly inherited recessive disease in the United States, and it's an equal opportunity. It affects both, sons and daughters, and the parents are carriers. Both parents have to be carriers, and they then, if the child receives a cystic fibrosis mutated gene from both parents, then they have the disease. It is chronic. It will eventually lead to the child's death. And one of the things that I am amazed at is it's a gene that is mutated, and it's only, I don't need you to know phenylalanine, but it's just like one amino acid out of 100,000 amino acids that is changed and mutated, and that child is doomed. And I just find it amazing when it's just one amino acid out of 100,000 that kills a kid. But it's a protein that is mutated. It has the name from hell. On the exam, I would use the abbreviation. And the other thing is I would call it a chloride ion channel mutation. But it called CFTR stands for cystic fibrosis transmembrane conductance regulator. Hello. What it is that it's a gene that codes for a protein that inserts itself in the membrane of the cells in the lung, and it stops chloride ions from being able to freely move. Chloride as of sodium chloride. and potassium chloride. And these salts are able to alter the water content inside the cell and the fluid surrounding the cells of the lung, such that you have less and less water. And you don't, and I spend so much time about pulmonary edema, but now you're talking not about the alveolar sacs, you're talking about the fluid in between the cells of the lung. And what then happens is that with the lack of water, the mucus made by the goblet cells are going to become very thick, and it's going to clog the air passages. And that's also going to be the breeding ground for bacteria. So children with cystic fibrosis have pneumonias after pneumonias after pneumonias, and after a while, it really starts to destroy a more and more of the lungs, so the respiratory function goes down and down, making it more and more difficult for them to fight off infections such as pneumonia, and eventually they will die of respiratory failure. Again, they're going to have a hard time breathing in as well as breathing out due to inflammation, which is going to cause bronchoconstriction, a lot of that thick mucus, which is also going to inhibit inhalation and exhalation. So cystic fibrosis, like TB, for very similar reasons, with the air passages and the alveolar sacs being destroyed, are also going to be type 2 respiratory failures. And pneumonia as well, but pneumonia tends to be resolved fairly quickly. It's really the very young and the very old with the pneumonias and compromised immune systems where you have death. Most people with bacterial viral pneumonia is self-limiting and not long-term damage. But with people with TB, tuberculosis, and cystic fibrosis, they are chronic and progressive, and eventually you're going to destroy enough of the lung for them to die. So that's kind of that. And I think this goes into the fact that the chloride ion mutation, the channel doesn't work, too little water, mucus cannot be diluted, and so it becomes the breeding ground for pathogens and slowing inflammation and destruction of the lung. And some of these YouTube, like 3-minute animations, click on them, enjoy them. And this is the last slide. So this is showing you that a child with cystic fibrosis not only has problems with the lung, but they have problems making digestive enzymes. They have problems with the ducts, both the fallopian tubes and the ductus deferens in males, fallopian tubes in females. They also get clogged with mucus, but being sterile does not kill you. Taking digestive enzyme is a solution for the problems with the pancreatic duct, but there's no solution for the lung. And until that happens, or until we can find a way of correcting that mutation for the chloride ion channel, the lifespan back in my day was probably 13, 14. Now, with a lot of intervention, people with cystic fibrosis can live to their 20s and early 30s, but death is the ultimate and the progression of the disease, the person dies. And so on that happy note, that's the end of the pathophysiology on the respiratory system. Okay, so